All right. Good morning, P10 Ice Daily Show. Happy Tuesday morning. Hope your day is off to a great start here a little bit early today. My name is Alan. I'm happy to be your host today. Currently have the pleasure of serving as the Chief Operating Officer for ICE, as well as a lead faculty in our fitness athlete division. I got some wedding stuff going on today, so going on here early before my day gets started, talking about manual therapy versus exercise today. So before we get started, some courses coming your way. Our last online course that is starting before Thanksgiving is going to be Clinical Management of the Fitness Athlete, Pregnancy and Postpartum with Christina and Alexis. That will start November 1st. And then our last online course of the year will be Clinical Management of the Fitness Athlete Essential Foundations. That's with myself, Mitch Babcock, Kelly Benfey, and Guillermo Contreras. That will start December 6th. That'll be our last online course for the year. Down to just single digits for live courses coming your way. November 6th and 7th, so next weekend, we have Extremity Management down in Knightdale, North Carolina. That will be with Lindsay Huey and Kristen Nett. That same weekend, you can catch Justin out in Pasco, Washington in the Tri-Cities area for total spine thrust manipulation. And then down in Ohio, you can catch Christina, Jeff Musgrave, and Alex Germano for Modern Managing the Older Adult Live. The weekend of November 13th and 14th, we've got Rehab of the Injured Runner down in Atlanta with Jason London. We have Fitness Athlete Live in Chicago with Zach Long. And then we have another chance to catch Justin for Total Spine Thrust. That'll be in Bear, Delaware. And then our very last live course of the year will be the weekend before Thanksgiving. That will be Extremity Management out in Denver. That will be with Lindsay Huey. So a couple more chances to catch us before the end of the year, live or online. So what are we talking about today? We're talking about something we have been going back and forth on since, I don't know, maybe the start of the profession. Manual therapy versus exercise. Which one is better? If I could only pick one, which one would I do? So we're going to talk about applications and what we think we're doing with each thing. And then we're going to talk a question we get a lot, especially working with a more active population, is if you are using manual therapy, how are you timing it? When are you deciding to use it? How long? That sort of thing. Before exercise, after exercise, those sorts of questions. So getting into the first part, which is something we'll probably, I imagine, be talking about until the end of humanity, is which one is better, manual therapy or exercise? I think it's really important to know that when we look at, in the research, what's happening with either one, for almost every condition that we treat, we need to recognize that we're doing the same thing. That whether we're using lumbar traction or hip long axis distraction, whether we're using cardiovascular exercise on a bike or a rower, or whether we're doing strengthening, we're really doing the same thing, at least from a short-term change perspective, which is we're reducing symptoms, right? We're either using our hands, we're creating a pumping mechanism that's reducing inflammation and therefore reducing symptoms and making the person feel better, increasing muscular activation, improving range of motion. So whether we have somebody come in and we pull on their leg or we go get them on the bike, we're all kind of chasing the same result through different applications. So it's important to know we're all after the same goal, even if we go to exercise first or manual therapy first is our first choice of intervention. Now, I think it's really important, and I won't get too much into this because we talk a lot about this in our lumbar and cervical management courses, that it's really important, we think, to grab the short-term change to then facilitate the long-term change. That if we can use our hands or use exercise to reduce symptoms a little bit, we get a lot of patient buy-in and we get a lot more buy-in for that person then to maybe stay committed with us for a longer course of care, where then we can do long-term loading and get all the nice benefits that come from loading. And it's important to know, as much as we love manual therapy here, that we're always chasing load as the long-term option with every patient whenever possible. That increase in tissue capacity means that person is less likely to enter the dumpster fire that is our healthcare system in the future, right? If we can get them a little bit stronger, they're less likely to be injured in the future and less likely to need to come back to see us or another healthcare provider and stay out of the healthcare system at all costs possible. So important to know we're after the same goal, whether we choose to go manual therapy or exercise first. It's really important that we use either one to get that short-term change that causes long-term buy-in. And then always progress to load, even if you choose manual therapy first. And really diligent load here, right? Lifting above 60% of our max, using a lot of time under tension and tempo, really getting tendons and muscles and joints a lot stronger. Now, what about timing manual therapy? When should we use it in the course of care? Well, if we're thinking we need to reduce symptoms, if somebody walks into the clinic with 10 out of 10 pain, we should probably choose to do it before exercise. That seems the most civilized way to approach it. And again, if we're thinking about pumping inflammation, then maybe we're going to longer term joint mobilization, or maybe something like dry needling with electrical stimulation, right? We're getting that muscular pump. We're starting to flush some inflammation. Otherwise, if we're just thinking about we're just modulating symptoms, we don't think maybe there's inflammation there that needs to be pumped out, or maybe we're dealing with a patient with persistent pain, then really anything is kind of fair game. Spinal manipulation, joint mobilization, dry needling, cupping, what have you, mobilization with movement, just to get some sort of different stimulus to the brain that's going to increase the likelihood that that patient wants to move. So if we're thinking reduce symptoms, definitely prior to exercise. If we're thinking muscular activation, there's an awesome amount of research on both dry needling and spinal manipulation that looks at using them prior to exercise just for the muscular activation component. With people with or without active symptoms, without active pain, getting some needles and stimulation in people or cracking their bones, getting that muscular activation has a big impact on performance output with exercise. So you'll see a lot of literature, especially with rugby and lacrosse and professional soccer teams, of literally every player before they go on the field getting their back cracked or getting dry needled, knowing that that's going to increase muscular activation, especially spinal manipulation has a good effect on stuff like quadricep muscular velocity and maximal force output. And so if you want to kick a ball harder, longer, faster, then getting your back cracked before the game has shown to have a really nice effect on that. So you see a lot of professional sports teams using spinal manipulation and stuff like dry needling before a game, even if folks are 100% asymptomatic, they don't have an injury that they're currently worried about. So if we're looking to improve range of motion or muscular activation prior to exercise, then maybe we're looking at spinal manipulation and/or dry needling. And now recovery. This is something as physical therapists we're not very comfortable at all doing, of having folks come in who maybe have no symptoms at all and just want to utilize manual therapy, maybe spinal manipulation or dry needling as a recovery modality, maybe between events, right? Maybe even events in the same day, or maybe they have a couple events in the same week, right? We have our high school and college athletes who may be having multiple games in a week, using manual therapy as a recovery modality. This is something other allied healthcare providers are very comfortable performing, but something that we need to get a lot more comfortable doing, and also understanding the timing of this, of that if somebody is coming in to see us on Wednesday and they just had a game on Tuesday and they have another game on Thursday, it would not benefit the maximal performance of that athlete to crush them in physical therapy on Wednesday with exercise, right? We know that's going to make them sore. We know it takes about 80 hours to recover from vigorous loading, and that if that person is coming into our clinic Wednesday afternoon and they are going to be playing a game maybe Thursday morning or Thursday afternoon, that's only 12 to 24 hours after they've worked with us. We know they're probably going to be sore, and we know their muscular performance is definitely going to be impacted. If we imagine that super compensation fatigue curve graph of what happens when we exercise, immediately after loading, that graph tanks, right? Your fatigue level tanks, and you are not able to give your 100% best because your muscles are fatigued. And so we do a lot of disservice to our athletes who come in, and we are so obsessed with loading them and loading them heavy and loading them vigorously, which is usually the right answer, but not in this case. That can really mess up that person's performance. And if you've never done that before, trust me, that's an earful you're going to hear from that athlete when they come back in and say, whatever we did, I never want to do that again because you made me so sore. My game the next day really sucked a lot, and that's your fault. So getting comfortable using manual therapy as recovery of today is not the day to crush this person with load. Maybe today is the day to do some dry needling, maybe some joint mobilization, keep it a recovery style visit, get them ready for that game they have tomorrow. We know that doing some dry needling with electrical stimulation can prime the muscles, can pump out some inflammation, make that person a little bit more ready to play that game tomorrow in a way that's not going to make them sore and is not going to affect their muscular performance. So getting more comfortable timing manual therapy after exercise or in place of exercise when somebody is actively in season with a sport or otherwise has a vigorous exercise event that's about to come up. And then the last part here is just patient expectation. Do we give manual therapy after physical therapy is done for the day, maybe as like a nightcap, right, as a way to say job well done? I'm not a big fan of that. I think that really facilitates a lot of dependency because eventually we're going to get to the point where physical therapy is done and an independent person doesn't expect, well, most independent people don't expect to have their muscles rubbed every time they're done exercising, right? You finish at the gym, you pack up, you go home, you take a shower. You aren't expecting a full body massage after every single time that you exercise. So I think that can facilitate a lot of dependence, but I also think if you are working with that patient, you know them really well. If you think that is a big part of their expectation that keeps them coming back, then certainly there's a place for that after exercise. And then just having the conversation of, this can't go on forever. We'll need to eventually move away from this. And just having that discussion of, eventually you'll get to the point where you don't feel like you need this after exercise every time, and then slowly tapering that off. And then my last point here is just something we talk about here at ICE all the time about and not or. Of why does it always have to be or? Why does it always have to be manual therapy or exercise? Why can't it be both? Why does physical therapy have to be 60 minutes of manual therapy only? If you exercise people, you're a personal trainer, or vice versa. If you only manual therapy people, you're a massage therapist or something like that, and it should be 60 minutes of vigorous intensity and really high loaded exercise. It has to be some combination of both based on where the patient is at. And even getting more creative and thinking outside the box of what about even using manual therapy during exercise? This is something almost none of us are comfortable doing, but it's something we do here a lot at Health HQ. Pull a treatment table out into the gym and maybe have somebody set up and do a remom where they're maybe moving through a motion that is maybe a little bit symptomatic and then using manual therapy within that EMOM to calm their symptoms back down. So they're able to tolerate that load, perform it, get all the benefits of load, and then use manual therapy to calm those symptoms back down so that it don't get continually more and more and more flared up. So a good example here that I just wrote out really quickly, what about a 12-minute remom? Maybe minute 1, we're doing 4 deadlifts at 65% of a 1 rep max. Maybe that's aggravating that patient's symptoms. Maybe they're going up from a 2 to a 5. Maybe minute 2, we're on the assault bike. We're just easy spinning. We're doing some cardio. Maybe that's still not enough to calm that patient's symptoms down. Maybe they're still hanging out at a 5, but maybe they get a lot of relief with lumbar traction. So maybe after they get off the bike, they lay down on the table, you grab your mobilization belt, and you give them maybe 45 seconds of lumbar traction, which calms their symptoms back down to a 2. Now the clock beeps. Boom, we're back to deadlifting. Deadlift, bike, traction, deadlift, bike, traction. So we're still getting all the benefits that we would be getting from loading normally, with the added benefit of using the cardio and the manual therapy to keep those symptoms low so that we can continually tolerate more and more load. So just getting comfortable incorporating all of this stuff together and not in isolated silos of maybe getting a little bit more comfortable doing manual therapy during exercise, during a rest interval. Oftentimes patients are just standing around between breaks on exercises. That's a great time to use maybe mobilization, maybe traction, maybe something like that. Obviously not practical in a 1-minute interval to do dry needling. That would take more than a minute. But there's a lot of stuff we can do with our hands to calm symptoms down while the patient is actively exercising, which increases their tolerance to be able to perform more load. So just give that a little thought about maybe trying to combine some of this stuff together instead of always compartmentalizing it. So manual therapy, when and why? We are after the same goal with manual therapy and exercise. We need to understand different timings of when to use it, of using it to chase a short-term change that builds into long-term change, and that we're always after the same goal of reducing symptoms to better be able to tolerate load. As Jeff Moore would say, how fit will you let us get you? And then getting more comfortable combining these things together. Maybe start to play with using manual therapy during your active exercise so that patients can better tolerate exercise. Oftentimes, patients get a little fed up with exercise and we panic and we scrap the exercise altogether and we just go to the manual therapy. But maybe if we can combine these things together, the patient can actually stick with the exercise and use the manual therapy to calm their symptoms down over time. So give that a try. So I hope that helps. Would love to hear any discussion you all have about this. I will be gone for the next couple weeks. I'm getting married on Saturday and going on my honeymoon, so I will be unplugged 100% for a couple of weeks, but I'm looking forward to seeing you all back here in about 3 or 4 weeks. Hope you all have a fantastic start to November. Thanks for being here this morning. Bye, everybody.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.